Assalamu alaikum, ladies and gentlemen. My name is Professor Alyscia Cheema, and I would like to welcome you all to the webinar on Ocloplastics and Aesthetics. This webinar is being organized by the Women in Ophthalmology of Pakistan. This is the 5th webinar in the series, and hopefully this will not be the last. Since you all know now, after COVID, towards the end of COVID, inshallah, we are restarting our conferences and seminars. But we've had a really nice time during this pandemic, not the pandemic itself, but the webinars that we've been hosting and all participating in. So we have organized this webinar on Ocloplastics and Aesthetics, and it's mainly geared for the ophthalmologists who are in training and for those people who would like to dabble a bit in Ocloplastics in their practice. So we have an array of experts from all around the world, and I'm going to introduce each one of them now. So first of all, my introduction. I'm a meritorious professor at Jinnah Sindh Medical University in Karachi, Pakistan, and I'm at the head of the Department of Ophthalmology in Jinnah Postgraduate Medical Center. I have about 25 years experience in ophthalmology, and I have trained over 45 people for their FCPS and a few for FRCS in ophthalmology. So I'm going to share my screen now, and we're going to start the introductions. So our first speaker is Dr. Adeela. She's from the UK. Dr. Adeela Malik is a triple fellowship trained consultant, ophthalmic and oculoplastic cosmetic surgeon. Having completed her general ophthalmology training at the world-renowned prestigious Moorfields Eye Hospital, she undertook 3 oculoplastic fellowships at Maidstone and Tunbridge Wells, Chelsea and Westminster and Moorfields Eye Hospitals, working with world experts. She is currently the lead for Oculoplastics and Mohs reconstructive surgery at Southend University Hospital, Mid and South Essex NHH Foundation Trust. Dr. Adeela is the lead for education and the college tutor for the Royal College of Ophthalmologists at Southend University Hospital. She is also associate lecturer in ophthalmology at Anglican Ruskin Medical School. So welcome, Dr. Adeela.
Thank you for having me.
Next, we have Dr. Vaness Neoh from Malaysia. Dr. Vaness obtained her FRCS in ophthalmology in 2003. She underwent oculoplastic subspecialty surgical training in Rotterdam Eye Hospital, the Netherlands, National University Hospital, Singapore, and Serdang Hospital, Malaysia. She started the oculoplastic department in the Penang General Hospital, Malaysia. She is currently practicing in Island Hospital, Penang, Malaysia since 2016. One of the founding members and at present chairperson of Malaysian Oculoplastic Group, counselor in the APSOPRS since 2018, and she is part of the executive committee in WOW, Women Ophthalmologists Worldwide, and she has been awarded the Excellent Service Award by the Ministry of Health, Malaysia. So welcome, Dr. Vaness.
Thank you.
Next, we have Dr. Maya Hada from India. Her present designation is Assistant Professor and in charge Ocuplasty and Ocular Oncology Services, SMS, Medical College and Hospital, Jaipur. She is an ex-consultant and in charge Oculoplastic Services, Medanta, the Medicity Hospital, Gurgaon, and she is a member executive of Occuloplastics Associations of India, Women Ophthalmologists Worldwide, and Women Ophthalmology Society of India. Welcome, Dr. Maida.
Thank you.
Our next speaker is Professor Sofia Iqbal from Pakistan. Professor Sofia Iqbal earned her medical degree from Hada Medical College in 1995. She was a position holder in all professional exams. She started her ophthalmology residency in 1998 at Hayat Medical Complex, Peshawar, as an FCPS trainee. In 2000, she went to the UK and has worked in the NHS on training posts approved by the Royal College of Ophthalmologists till 2005. In 2001, she obtained her FRCS Ophthalmology from the Royal College of Physicians and Surgeons, Glasgow, and MRC Opht from the Royal College of Ophthalmologists, London. In 2011, she did her fellowship in refractive surgery from Germany. She was a pioneer member in establishing refractory surgery services in KPK, and she has also completed her CHPE. Next, we will thank you for coming, Professor Sofia.
Thank you very much for having me.
Our next speaker is Dr. Saba Alkhairy from Karachi, Pakistan. Dr. Saba is an FCPS, and she is currently the Assistant Professor in Ophthalmology and a faculty member in the Dow University of Health Sciences, Karachi. She is also an examiner of MBBS at the Jinnah Sindh Medical University and Dow International Medical University. Dr. Saba has experience in different private and prestigious institutions like Aga Khan University Hospital and Hashwani's Hospital. She's also a member of the South Asian Oculoplastic Associations. Welcome, Dr. Saba. Our next speaker is Dr. Nausheen Hayat from Karachi, Pakistan. Dr. Nausheen is a consultant orbit and oculoplastic and pediatric ophthalmologist. She has experience of more than a decade in ophthalmic practice. Currently, she is a specialist registrar at the Western Eye Hospital, London, UK, and has also served in Pakistan in JPMC, Karachi as a consultant orbit and oculoplastic surgeon. Dr. Nausheen is a joint secretary of the Pakistan Oculoplastic Association, and she established the first orbit and oculoplastics clinic in the largest tertiary care center as a chief resident. So welcome, Dr. Nausheen.
Thank you. Thank you so much for having me.
So we are going to start the panel now, the panel discussion, and I will be asking you questions, and please give your answers within the 3 minutes so that we have some time at the end of the session that we can take up some questions and answers from the audience as well. So we will start with Dr. Sofia. So this is your question, Dr. Sofia. Dealing with the pediatric population, at what age would you recommend ptosis surgery in children and why?
Thank you very much. Ptosis is a condition in which the direction or position of the upper eyelid margin is lower than normal when the patient is looking straight ahead. If it happens at birth or in the first year of life, then it is known as congenital ptosis. Congenital ptosis can be a simple congenital ptosis in which only the levator muscle is affected, and that happens, and it is unilateral in 75% of the cases. It may be a part of a syndrome such as blepharophymosis, or it may be associated with jaw winking. Sometimes congenital ptosis has got a superior rectus weakness as well, and then we can call it a double elevator palsy. Ptosis can be associated with refractive errors, astigmatism, anisometropia, and squint. When to operate, it depends on the amount of ptosis and the risk of amblyopia. If the visual axis is covered and if there is risk of amblyopia, then we have to operate as soon as possible. Usually it's a sling procedure, and the material of choice can be silicone, proline, and preserved fasciolata, depending on the availability of the material and the expertise of the surgeon. Sometimes there is chin elevation and there is risk of deformity of the neck and maldevelopment, which can further lead to gait abnormalities. Even in that case, we have to operate as soon as possible. If the risk of amblyopia is not there, then you can observe the child regularly on regular follow-ups, and you can take photographs on regular intervals. And then you have to wait till the preschool age, which is 4 to 5 years of age. Why is this age important? Because for the psychological development of the child, all the asymmetry should be addressed before the child meets his own age group. So this is important. And the other thing is surgery become very easy at this age, and tissue plane dissections are easier. And measurements upon which the success of our surgery depends, such as marginal reflex distance, skin crease, levator function, palpebral aperture height, Bell's phenomena, all, they can be done easily on a much cooperative child. But even then, it's very important that measurements should be taken several times to make sure they are done correctly, because as I said, the success of the surgery will be dependent on that. So I'll summarize it up. If visual axis is clear, risk of amblyopia, gait abnormalities, neck deformities as soon as possible. Otherwise, the preschool age is the best age. for children, which is 4 to 5 years of age. But in my personal experience, we have been operating on congenital ptosis even when they come as teenagers. So that's all.
Thank you.
Thank you.
Thank you. Our next question is for Dr. Nausheen. And the question is, what are the various synthetic and non-synthetic sling materials used in sling procedures, and what are the possible complications to look out for?
Thank you so much. Good evening, ladies and gentlemen. So we have got a list of synthetic and non-synthetic sling materials. It's a long list, but I have included most of those materials which are readily available in our region and readily frequently practiced here. So among synthetic materials, we have got non-absorbable sutures in which there is proline and nylon sutures. Then comes the merceline mesh, supramate sutures, and then comes a silicone material in which we have got silicone rods, silicone bands, elastics, which is another name of silicone band. Then we have got polyester mesh, and there's another material which we call expanded polytetrafluoroethylene or Gore-Tex. So among these, I'm going to start with the proline first. Proline is certainly very frequent. The advantages for the proline are it's cheaper in the cost, frequently available. It has got higher visibility, reduces the surgical time, and can cause less inflammatory reaction. But the disadvantage the main disadvantage is it loses very frequently. So whenever I do, I have to use proline in my patients, particularly in young children, young infants. I always counsel parents that they should be ready for another surgery in soon, maybe 6 months, maybe 1 year, depending on the condition. They might need another surgery too, because the ptosis will come up again. So extrusion can happen because the proline cannot disintegrate with the fibrovascular tissue, so it slips very frequently. Then comes the silicone. Silicone is very elastic. It gives long-term results in children, but it's more useful in myogenic ptosis or those who have got poor bells in them, because we can easily frequently readjust silicone bands of the silicone sutures. Usually preferred in children because it can give long-term results. But in my personal experience, now I try to avoid silicone in very severe congenital ptosis, and particularly cases of blepharoplasty, in which we have got to deal with many issues like the epic and thick fold. So we cannot achieve the desirable contour of the lid, and we cannot raise it. The disadvantages are the granuloma formation, infection, and extrusion. It's rare to happen, but these are the things. Then third, I have got merceline mesh. Merceline mesh and the expanded polytetrafluoroethylene. These two materials literally change the ptosis surgery around the globe. It reduces the surgical time, get very good results. You can easily use in children, particularly children less than 3 years of age. It can give better crease, better contour. But the disadvantages, am I short of time?
Please just complete your answer.
Permanent scar marks. It can give a higher extrusion of the sling and granuloma infection formation. And then I have got expanded polytetrafluoroethylene. It is an amazing thing. It is a biosynthetic material which has got very small pores in it. Easily the fibrovascular tissue can integrate in it, and gives very good results all over the world. Several studies has been done, and it has given almost 99% results. I've personally used it, and better high tensile. It's high tensile, give better contour, short duration as well, and can be used in children in which facial lata cannot be done. But the disadvantages is the granuloma formation and extrusion. So the another thing which is similar to this, that is Gotex strip or Gotex suture. So Gotex suture and EPTFE, both of these are same things. Gotex comes in a suture form. It's Gotex usually used in the cardiac surgeries. It is available for the scleral, as a scleral suture for the intrascleral surgeries. So it's up to you if you want to use the Gotex suture or these EPTFE strips. These are available in Pakistan as well. So
thank you, Dr. Nausheen.
Okay.
Thank you. That was a really detailed answer. So I'm moving on to the next question. This question is for Dr. Adeela. What approaches, in your experience, work well in a case of jaw winking ptosis?
Okay. First of all, thank you very much for having me here today, Dr. Alyscia, and the whole WIOP team. The first thing is you need to understand what is Marcus Gunn jaw wink, what is Marcus Gunn ptosis. And we know that that is a synkinesis of the ipsilateral pterygoid muscle. Once you've understood this, it's very important to take a detailed history from your patient so that you understand what is it exactly that they want you to fix for them. And this really can be divided into two categories. Is it an aesthetic problem that the patient is not happy with the height of the lid? Or is it a problem that they just don't like that every time they chew, the lid goes up and down and they get the jaw wink? So if we are talking about the aesthetic problem, the surgical correction depends on the levator function. If they have a decent levator function, let's say 10 or more, you could do a simple levator advancement surgery. However, if the patient's main concern is the jaw wink, then the treatment is really to disinsert the levator muscle and to then do a frontalis or brow suspension. Sometimes you can get away with doing this surgery on a unilateral side, but if the jaw wink and the ptosis is quite bad and you want to make sure that both eyes are even, then you can disinsert the levator muscle bilaterally and do a bilateral brow suspension.
Yes, you're right, Dr. Adeela. It's a difficult topic, and I think we need more detailed discussion on that. And I find that patients are not willing to accept a bilateral suspension if one eye is normal. So that is the dilemma that we're usually in when we're dealing with such cases of ptosis. Now I will go on to the next question. So this question is for Dr. Saba. What are the periocular skin changes with age, and how would you care for an older patient with ptosis? Please unmute your mic, Dr. Saba.
Sorry, am I audible now?
Yes.
Okay. Thank you for having me. The periocular skin changes with age are, overall there's a loss of elastin and collagen, so the skin becomes loose. And what happens is that the eyebrow starts to droop, and there is dehiscence of the levator aponeurosis or disinsertion, which leads to aponeurotic ptosis. Other periocular skin changes include there's medial canthal tendon laxity, lateral canthal tendon laxity. There's overriding of the pre-septal orbicularis over the pre-dorsal orbicularis, and that can result in entropion. You can have an ectropion. There is herniation of the fat pads, and that associated with thinning of the orbital septum can lead to baggy eyelids. So, all in all, what is happening is you can have dermatochalasis, you can have aponeurotic ptosis, you can have baggy eyelids, there can be ectropion, and there can be entropion. Coming to the second part of the question as to how aponeurotic ptosis can be dealt with, surgically, you can have an interior approach as well as a posterior approach. So with an interior approach, you make a skin crease incision and you identify the end of the levator aponeurosis that has retracted. And once you do that, you can resuture it to the tarsal plate, and that would correct the ptosis. You can also use a posterior approach where you approach it through the conjunctiva. The procedure is essentially the same. You're identifying the cut end of the levator aponeurosis and you're suturing it to the dorsal plate.
Thank you, Dr. Saba, for your detailed answer. And I always found that dealing with senile ptosis is a much more simpler procedure than dealing with ptosis in the pediatric population, because you get that lax skin and you can play with the tissues, and it's not such an extensive procedure when you're resuturing the aponeurosis.
You can even do Ocuplasty if you want to correct the dermatochalasis in the same procedure.
Yes, that's true. And you get very happy patients. It's easier to, you know, get that symmetry and the results that you're looking for. So our next question is for Dr. Vanessa. So if you're dealing with a case of brow ptosis, what do you think? Do external lifts work?
Thank you, Alyscia, for the question. Can I share my screen?
Yes, please go ahead.
So there are many techniques for brow lift, and let me try and share my screen first. Okay, I can't share because other participant is sharing. Oh, so how do I?
Alyscia, you need to stop share first,
Yes.
then she can.
We'll stop it. Okay, go ahead, Dr. Vanessa.
Okay, let's try. Okay, so going on to brow ptosis, there are many techniques for brow ptosis, and the technique depends upon the indication and the severity of the brow ptosis. Normally, how do you know whether a patient has brow ptosis or not? You put your finger at the eyebrow of the patient at the orbital rim, and you feel and see whether the skin is below the orbital rim or is it above. If the skin is above the orbital rim, if the eyebrow is above the orbital rim, then he doesn't have a brow ptosis. But if the eyebrow is below the orbital rim, then the patient has a brow ptosis. So the common techniques employed for brow lift are direct brow lift, temporal brow lift, bicoronal brow lift, endoscopic brow lift, internal brow plexi, and chemical brow lift. Now, all techniques work quite well. If the patient has a brow ptosis because of a facial nerve palsy, a unilateral brow ptosis, then I will go for a direct brow lift because it works really well, but sometimes there's a risk of scar on the incision site. Temporal brow lift, bicoronal brow lift, and endoscopic brow lifts are good for patients who need to undergo cosmetic surgery. In temporal brow lift, I commonly do this procedure. It's a simple procedure wherein they have drooping of the lateral part of the eyebrows, and I make an incision behind the hairline and lift the eyebrow from there. For bicoronal brow lift, it's a little bit complex. You need a large incision, and I don't generally perform this unless it's really indicated. Internal brow plexi is also a very good procedure for brow lift, wherein I combine it with blepharoplasty. When I'm doing my blepharoplasty, mainly for cosmetic cases, I just put 1 or 2 sutures with Vicryl, and it gives a good, nice lift to the brow. So in short, one has to choose a technique depending upon the indication and the severity of the brow lift. This is a patient with a lot of overactive brow depressors such as the orbicularis, and just injecting Botox gets rid of the wrinkles and gives slight lift to the eyebrow. This is a patient with facial nerve palsy. You can see unilateral brow droop, which has improved with the brow lift, a direct brow lift, but you can see there's a slight scar here. So this is a patient of mine for cosmetic who had brow droop, and she underwent brow lift, wherein I made the incision just behind the hairline and lifted her eyebrow. And this is a patient who had dermatochalasis and also brow droop. So I did a blepharoplasty and did an internal brow plexi, and this gave a good outcome. So in short, all techniques work for brow lift, and everything depends upon the indication and the severity of the brow ptosis. Thank you.
Thank you very much. That was a very nice and detailed answer. I'm going back to our original topic. We were discussing ptosis, and I'm going to ask the question from Dr. Maya. Sorry, Dr. Maya, I think I skipped over it, or I don't have it on the screen, but I will just maybe read it out to you. I don't see it here on the screen. when you're operating on a patient with ptosis, what are the complications and how to look out for them?
Yeah, thank you, Dr. Alyscia. So I will need to share my screen first. So I'll take you through a few cases of ptosis surgery, and I'll first discuss the sling surgery and its complication. I'm not able to share it. Okay. Yeah. So can you see it now?
Yes, we can.
Okay, so these are few cases that were referred to me. Here you can see that the sling has been extruded out from the forehead stab wound. And why it has happened so? Because of the suture granuloma, and maybe the pocket which needs to be created was not created well. So this is how you make a vertical pocket while making your incisions. And then at the end of the surgery, you have to bury the sleeve along with your whatever suture you have used. I will advise not to use the proline or non-absorbable suture with long protruding ends, and that is how you can secure your sleeve without the risk of suture granuloma or extrusion. So the one more important thing that you need to keep in mind while doing the surgery is that your needle of the sling is not cut through the tarsus while doing the surgery. So you have to always evert the eyelid and check for that. Then the direction of the needle while doing the surgery should be like from the tarsus towards the brow, not in the opposite direction, to avoid the perforation of the globe. And in those cases, you should always use a corneal protector if you are doing that ways. So apart from sling, if you're doing fascia lata, then be careful not to injure the underlying quadriceps muscle while harvesting the fascia lata, and always close in 2 layers to avoid any prolapse of the tissues post-surgery. Now, fascia lata is a tough material. You did not need to put any sutures while tying the knots. And be careful for the cornea because it's a tough material, and the leg of ophthalmos is far more than that happens in the silicone rod. Coming to the LPS resection surgery, I will skip the whole video in the interest of time. Just to make one point here is that while you are passing the sutures from the LPS onto the tarsal plate, you must again put all the 3 sutures at the same height to avoid any lid notch, and then check for if the suture has not gone full thickness by everting the eyelid. Then to avoid the medial notching, you should always tie the medial suture towards the end of the surgery and loosely. Lid lag and leg of ophthalmos are inevitable, but they should not risk the cornea. And if it is risking the cornea and causing any exposure, like in this case, you have to revise it. I did this overcorrection in this child and I have to revise the sutures, and now he's doing fine. Lastly, I will just make one point about Fasanella servet surgery, that you should leave at least 4 to 5 mm of the tarsus while doing tarsectomy in this particular surgery, and use 2 clamps to avoid any lid notching and avoid any kind of abnormality in the lid contour. And while closing the incision, you can use a running suture 80 Vicryl, and always tie the knot on the skin side so that the cornea is not eroded.
Thank you.
Okay.
Thank you, Dr. Maya. So I'm sorry, I might interrupt if we're going over time.
Sure, no problem.
Want to complete the session, so I apologize for that. It was really nice, your answer. So now we're going to shift to the next topic, and this is mainly questions about facial nerve palsy. The first question will be asked from Dr. Saba. So what are the immediate and long-term challenges faced by a patient with facial nerve palsy?
The immediate challenges faced by a patient with facial nerve palsy are that immediately as you see a patient, you'll see that he has brow ptosis, he has an upper lid retraction, he's got leucophthalmos, he may have a paralytic ectropion, and there is associated dry eye. In the long run, he can go ahead to develop a corneal ulcer or a corneal Vaness, and in a very severe case, a corneal opacification. So we can start off with simple measures. I mean, you encounter a patient with a facial nerve palsy. Our main aim is to protect the cornea, and for that, you can start him off on artificial tears, lubricating gels, watercolor serum, and maybe do a temporary dorsography or just ask him to close his eye with a pad at night. Other than that, if the dry eye persists, you can resort to other measures such as punctal plugging or portrait of the punctum. For the lid retraction, a temporary ptosis can be induced by botulinum toxin, or you can go on to use materials such as gold or platinum that can be sutured to the ptosis in order to address the lid retraction. For the paralytic ectropia, you can do a tarsal sling procedure, and that usually works in the patient. I'd like to share the screen.
Okay, please go ahead.
I don't think I have it here. Okay, never mind, I'm sorry. But it was just a patient that I wanted to show that had brow ptosis and paralytic ectropion. So we didn't really do a brow ptosis surgery. That wasn't very obvious, but because of this paralytic ectropion, we did a lateral tarsal sling and just addressed his corneal exposure with lubricant eye drops, and he was quite satisfied.
Okay, if we have time towards the end, you can show us your patient. Okay, so just to keep within the time limits. Our next question is for Dr. Adeela. So what techniques in your experience work well with lower eyelid retraction and scleral show?
So this is a really great question. And to answer the question, you first have to make sure that you understand the history of the patient and what is the underlying cause of the inferior scleral show and the eyelid retraction. So most commonly it will be either an involutional problem, or it could be related to, for example, thyroid eye problems or a paralysis of the lid. I tend to think about this in terms of measuring the degree of inferior scleral show in the first instance. And then I take a graded approach to deciding which surgery I would like to use to try and fix the problem. So if they have a mild inferior scleral show and mild eyelid retraction on the lower lid, I would do an inferior retractor release. And what I mean by that is I'd make an inferior incision along the inferior border of the tarsal plate of the lower lid. And then I'd make a small pocket and find the lower lid retractor and effectively release it and disinsert it. And that will give you a good 1 to 2 millimeter improvement of your inferior scleral show. If I needed to get a little bit more, say 2 to 3 millimeters, I would do a simple lateral tarsal strip, which I know is something we're going to talk about more a little bit later on. But that surgery is actually very effective in many cases, because you do have an option to elevate the lid a little bit, still keeping the patient looking like themselves. So if they then have a little bit more inferior scleral show, I would always want to try and make them look like themselves. So I would be inclined to do a lateral tarsorrhaphy, just so that they still have a good lid contour, but still effectively improving their ocular surface to minimize them getting any exposure keratopathy. And if I needed to do more than that, so if they had 4, 5 millimeters or more, really, in my experience, the thing that works best is to do a mid-face lift, to really lift up the whole of the mid-face to give them a lot of support to the lower lid and to lift it. And in doing so, you can get really good aesthetic results. And more importantly, you've really protected the ocular surface to prevent them from getting corneal exposure and other severe corneal related problems.
Thank you, Dr. Adeela. Moving on to the next question. This is for Dr. Vanessa. How would you deal with upper eyelid retraction? What are the surgical and non-surgical means that we have?
Can I share my screen, Alyscia?
Yes, please go ahead.
So for the upper eyelid retraction, we first need to find out what is the cause of the upper eyelid retraction. The most common cause is thyroid eye disease. Sometimes no cause can be found. You can do all the investigations and it just can be idiopathic. If the lid retraction is due to thyroid eye disease and if it is inactive, I opt for non-surgical. If it is active, then I will opt for non-surgical options. Firstly, we need to do adequate lubrication, especially at night, give them a lot of ointments and eye drops. And secondly, if the lid retraction is significant and is disturbing the cornea, causing keratopathy, I will opt for steroid or Botox injections over the upper eyelid retractors. And after that, if once the disease is not active, that means the inflammatory markers, the inflammation of the eye is down, the eye is wide, the hormones are all back to normal, and the antibodies are somewhat normalized, I will generally do a posterior approach, which means I turn the eyelid and I release the Mueller's muscle and to a certain extent the levator, and this gives very good results in mild to moderate lid retraction. Now, in severe cases where the lid retraction is quite large, about 3 millimeters or more, we need to do an anterior approach and sometimes from the anteriorly do a full thickness blepharotomy so as to totally release all the upper eyelid elevators. And in very severe cases, we might also need to put a spacer or a graft to improve the lid retraction. So I can't go to the next slide. Okay, anyway, since I can't go, I'll just stop share. And so how do I, for the non-surgical option, when I'm injecting my steroid or injecting my Botox, I turn the eyelid and like how you do a supratarsal triamcinolone injection for children, from the conjunctival side, I inject very small quantities of Botox, sometimes about 5 to 10 units. And if it's a steroid, the same way, I turn the eyelid and inject very small quantities, say about 20 ml, 20 milligram of triamcinolone injection. This is a non-surgical way. And once the disease is not active anymore, I generally go for surgical measures. Thank you.
Thank you. That was a really comprehensive answer. We will go now to the next question. Okay, this question is for Dr. Sofia. When performing a lateral tarsorrhaphy, how much would be the amount of tarsorrhaphy to perform?
Well, thank you very much. Tarsorrhaphy is a surgical procedure in which we suture both upper and lower eyelid. It can be done as a permanent procedure as well as a temporary procedure. And it is of lateral, medial, and central type. A lateral tarsorrhaphy is usually done when we are doing it on a permanent basis. And otherwise, there are several indications for this procedure, and it's a very rewarding procedure, and all residents should be able to perform it with ease. The commonest causes are when there is an anesthetic cornea, when there is a non-healing corneal ulcer, when there is a persistent epithelial defect, when there is a proptosis and there is a risk of exposure keratopathy, lid retraction due to thyroid or due to any other cause such as chemical injuries or scarring, etc. Tarsorrhaphy is also performed at the end of surgeries, such as in case of enucleation or evisceration in children in which you want to place a conformer there, as well as at the end of orbital surgeries when you want to reduce the conjunctival chemosis and congestion. For Bell's palsy, for floppy eyelid, it is done quite commonly. Now, how much to be performed depends on the needs of the patient, and it is individualized according to each patient. And better, the measurement should be taken when the patient is sitting, and if you are doing it on a unilateral basis, then you have to have symmetry with the other side to an acceptable level. And as you know that the temporal field will be affected, but the patient should have a clear visual access and he or she should be able to see. And the examiner or ophthalmologist should be able to do examination easily. I will show you a slide now just to make the concept clear. So this is basically the types of tarsorrhaphy. And as you can see, this one is with a drawstring in which you can open the tarsorrhaphy and examine the patient and examine the cornea periodically from time to time to see if there is a corneal ulcer which is being healed or not. This is how it will look like lateral tarsorrhaphy. And this is, I have included just to make the concept clear that we can do it on the medial side as well. Now, this was a patient with a non-healing corneal ulcer, and this is the central tarsorrhaphy. And this is the patient, as you can see, there is lower lid retraction and there's a lot of scleral show in exposure. So this is post-operatively. Another, you can see lower lid retraction. It's a bilateral condition in which then you have to do it so as to prevent exposure. This is another patient, as you can see, floppy lid, and there is lid rectropion, especially on the lateral side. And this is post-operative picture. So it all depends on the need of the patient, and from patient to patient, indication wise, you have to tailor it accordingly. But make sure that your visual axis is clear. It has to be symmetry with the other side, and the examiner should be able to see the eye. Thank you.
Thank you. Yes, many times patients who have permanent facial nerve palsy, you can save the cornea, you can save their vision if you do the lateral tarsorrhaphy on time. So it is important to know this procedure. The next question is for Dr. Adeela. Let me just get the question up. So, Dr. Adeela, what would be the importance of suturing the periosteum to the lateral orbital rim?
So this question really relates to one of the simplest surgeries that we do in oculoplastics, which is really the lateral tarsal strip surgery. And the beauty of the periosteum is that it's a tough, fibrous, collagenous structure. And that means when you suture to it, there is very little movement. You, of course, cannot put your suture through the bone itself. So the next best thing is the periosteum. And one of the advantages of suturing to the periosteum is that your suture itself will be buried quite deep, and it will be attached to a solid structure with very little mobility. In addition, remember that when you do a lateral tarsal strip surgery, you will also suture, for example, another layer on top of the periosteum, which will be your orbicularis to orbicularis suture, for example, with a 6-0 vicryl. And then on top of that, you will do your grey line, your lash line, and your skin sutures. Again, I use 6-0 vicryl. But when suturing to the periosteum, I should also make a point that I personally use a 5-0 vicryl suture, because it gives me a little bit more strength in the suture when attaching from the tarsal plate to the periosteum. Some people will use a Prolene suture, and there's absolutely no problem with that at all. My personal preference from my experience is to use vicryl because it loses its tensile strength within after 7 to 10 days. And after that, you start to get a slight inflammatory reaction as it breaks down, as the suture breaks down. And that in itself gives you a formation of a scar tissue, which actually adds to the strength of your pexy and the area that you're bringing your lateral tarsal strip to. So this is the reason why we suture to the periosteum and not to any other soft tissues, because if you did suture to anything else, you're very likely to not get the result you'd hope for, because your tissues move, and they certainly also change with age. Things droop, and therefore you may find that your surgery may not last as long as you'd hoped in tightening the lid, because you didn't suture to the periosteum. So always suture your tarsal strip to the orbital rim periosteum.
Yes, thank you, Dr. Adeela, for a very nice detailed answer. And that is a very important point. And we are doctors in training forget about the periosteum, that it's so important. That suture is like an anchor, and you don't want your procedure or your result to start, sagging down or not look good. So that is a very important point that you've made. I'm going to now go to the next question. So this question is for Dr. Nausheen, and I think you have published a recent paper on this topic as well. So what is your experience with pillar tarsorrhaphy?
Thank you so much. I would like to share my screen first.
Please go ahead.
I've got this little video which is very short. So I had a very good experience with this pillar tarsorrhaphy. Sorry, why I'm unable to play it. I had a very good experience with the pillar tarsorrhaphy. It's a semi-permanent tarsorrhaphy which can be done, particularly advised in facial paralysis, but we did in corneal ulcers. So we published a study last year. It was a 1-year study including 35 patients, and among all those 35 patients, only 5 went into the failure. So we had got almost 86% results. Advantages because it can, we have to basically make 2 pillars in the upper tarsal plate, which are sutured or anchored into 2 gutters, corresponding gutters into the lower tarsal plate, and we have to suture together. So the advantages are very good cosmetic results. It preserves the peripheral vision. Patient can easily put drops in the eye, and particularly from ophthalmologist point of view, ocular examination becomes very convenient for the ophthalmologist, and we can also always customize this procedure by making single pillar or double pillars, medial or lateral only. The only disadvantage I could found, or the complications I found, was like poor adhesions, poor hygiene. If the patient has got poor hygiene, the pillars cannot stay together, and that's it. Yeah, and lid retraction. This was one case in which we had who had facial paralysis, and the failure occurred due to the severe lid retraction, and the pillars were broken. So yes, if I can just show one more picture of this pillar tarsorrhaphy, and I almost many of my our residents back in there in JPMC were able to perform it. It's very easy to learn. This is basically the diagrammatic picture, in which the sutures pillars can be constructed. Thank you.
Thank you. Thank you. Really interesting, Dr. Nausheen. That's a new procedure for people to learn. And I'm sure.
Yes, ma'am. Sorry, very little work has been done globally. I believe we were the second, because people have mainly published in the form of case reports, but we have published the second study after like ages. The first study was published by Tenenbaum like in early late 19th century, like, so that was a good achievement, and you were also the part of it.
Okay, good to know that. Our next question is for Dr. Maya. We're still talking about patients with facial nerve palsy. So in which situations would spacers be used?
Okay, yeah, thank you, Dr. Cheema. So first we need to know what is the cause or the etiology of the lid retraction. If it is due to the tone of the orbicularis muscle, which is not there like in the paralytic atrophy or in facial palsy, or if it is due to the scarring or fibrosis of any of the lamella, which is causing the vertical shortening of the eyelid. So if it is due to laxity, then we have to correct it by the procedures that already been mentioned by Dr. Adeela, like lateral tarsal strip or horizontal lid tightening. But if it is due to the vertical shortening of the eyelid because of scarring, then we have to address that by spacer. And that too, if it is there in the middle or posterior lamella, because if it is there in the skin, that is the anterior lamella, that you can check by a very easy test. You ask the patient to open the mouth, and if the lid retraction increases in the lower lid, it means it's in the anterior lamella, and there you need to put a skin graft. And if it is in the middle or the posterior lamella, then you can use a spacer. And most commonly that I prefer is the hard palate mucosa, and that because it provides mucosal surface on the conjunctival site. And you can put it end face, that is directly over the conjunctival site, or and glove, like as Dr. Adeela has mentioned, make a pocket on the lateral aspect, and then insert the first to the retractor lysis of any adhesion, and then put the spacer between the lower edge of the tarsus and in between the lower lid retractor. And other spacer that can be used are donor sclera or medpore or ear cartilage, that is also very easy to harvest. So in these cases, I would like to prefer using spacers.
Thank you very much, Dr. Maya. That was an excellent answer. So we are now going to move to a new topic, and we're going to discuss contracted sockets, something that we do see very commonly in our tertiary care hospitals when we're dealing with these kind of patients. So the first question will be addressed to Dr. Vanessa. In a case of a contracted socket, what types of grafts would you use and how would you harvest them?
So there are many kinds of grafts that we can use for contracted sockets. The kind of grafts that we use depends upon the indication for this reconstruction. Now, supposing the socket is contracted in the sense that we need to enhance the volume of the socket, then we can use grafts such as dermis pad grafts. Or sometimes if an implant is exposed and we need to cover the exposed implants, then we can use dermis pad grafts. Dermis pad grafts are normally harvested from the gluteal region, the superior part of the gluteal region, the superior and the outer part, or you can harvest them from the abdomen. Now, apart from that, if there are other problems with the socket is contracted because there's shallow fornix, and we need extra mucous membrane, then we need to harvest a mucous membrane graft. The mucous membrane grafts can be harvested from the cheek, the buccal mucosa, or from the lower lid. And sometimes we can also harvest them from the nose. I've also used grafts from the inferior turbinate of the nose, and also from the hard palate. We can use the grafts from the hard palate. Apart from that, there are some other grafts which can be used for contracted sockets. They include the amniotic membrane graft, or we can use a fascia lata or a tuto patch, and these are also used sometimes. So these are all the various grafts that we can use for contracted socket. Thank you.
Thank you, Dr. Vanessa. The next question is for Dr. Nausheen. Let me get the question up here. Let me see. Okay, so when you are dealing with these contracted sockets, what difficulties do you face when you're dissecting the tissue planes?
Thank you so much. So for dissecting the tissue plane, firstly, we need to understand the anatomy and embryology of the human body, because it is very important. Why the embryology? Because many of the vessels, how they're gonna approach the organ, and eventually how they're gonna end up, this is really important to understand. So follow the Simeon's crease. Whenever dissecting the tissue planes, try to have a very good concept of anatomy, that you're not gonna cause any damage to the major landmark or the anatomical structure lying over there, and follow the symmetry. And then comes the most important thing is the handling and alignment of the blade. I would like to share a picture here. So, sorry, how to handle a blade. So the handling of the blade is really important. How to grab it. So if you can see that you have to hold it like a pen, this will give you a proper grip on your arm, and how to twist around your wrist and your elbow. I think these are the major basic surgical things which should be included in our surgical workshops and in the medical school as well. And handling, how to handle the tissue. So you not to have very strong or impact on the tissue. Try to be gentle as much as possible. Always say, respect the tissue, tissue will respect you. Very gentle, and pause if there is any resistance you're gonna find. And then comes the traction and counteraction. So you need to think that where you can apply which kind of force. like for instance, it's a very small thing. If you have to retract the tissue, just think, can you retract it with a retractor, or you just can apply a swab or a sponge over there, particularly when you are dealing with the longitudinal planes. Just apply a swab, retract it slowly, gently, and you can easily dissect these tissue. And when there are adhesions over there, always try to stop and look, okay, if there is an adhesion, how you can deal with it. Just another small example, if we have got a lesion here on the lower lid, which is more in a longitudinal fashion, and if we excise it in this manner, so the scar gonna be like this eventually after the outcome. So what can be done? Instead of going longitudinally, we can put a long almond-shaped incision around that lesion, which will the surgical that incision will eventually heal nicely, and the scar will gonna bury under the this bag and lines lines under the eyes. And last of everything, because we have got, a human body has been privileged to have two eyes, we have to respect the symmetry. The surgical outcome should be intended in order to get the maximum symmetry in both eyes. So you need to customize, you need to think that how you're gonna go and approach the surgical incisions, which will give you the maximum natural look and maximum natural symmetry.
Thank you. Thank you, Dr. Nausheen. And one thing I would say that always be careful of your hemostasis. Make sure that you're seeing what you're doing. Otherwise, you won't be able to, dissect all that fibrosis out. So the next question is for Dr. Adeela. How does an amniotic membrane graft fare over a buccal mucosal membrane graft when dealing with shortened fornices? Dr. Adeela, please unmute your mic.
Oh, sorry. Can you hear me?
Yes.
Yeah, so I thought this was a really excellent question because people don't always think about the various mucosal tissues that they're using. So a buccal mucous membrane graft is essentially a non-keratinized, stratified squamous epithelial tissue. And the advantage of a buccal mucous membrane graft is that it's easy to access, it's easy to harvest. You can get a large enough sample, enough to use and fix most fornices or lower lids that you might require. The greatest beauty of it, I think, is that it has the immunological properties that you would hope for in a patient's own tissues. So it's unlikely, it wouldn't become rejected because it's got its own immunological properties that the body already accepts. If I had to think about, would I be using a buccal mucous membrane graft rather than an amniotic membrane graft? My answer would always be that I would use a buccal mucous membrane graft for the reasons that I've mentioned, but also when you handle an amniotic membrane graft tissue, it's actually a very friable tissue, and it, to me, lacks the structural integrity that you would hope for to put into a moist and thick structured lid. As you know, the lid has an anterior and a posterior lamella, and you need something with a bit of structure to it and thickness to it, which an amniotic membrane graft cannot give you. Having said this, an amniotic membrane graft has its advantages. You could use it on the bulbar conjunctiva, or you could use it, very commonly over the cornea for corneal erosions and corneal exposure keratopathy type problems. But when specifically talking about the eyelids and the lower lid fornices, my experience and my preference is to always use a buccal mucous membrane graft.
Yes, that's right, Dr. Adeela, I agree with you. I think the only thing with buccal mucosal grafts is when you're harvesting it, you have to be very careful how deep you're going. You don't want to go deep into, the muscles and have a lot of bleeding over there. So you have to stay very superficial, and it's an excellent graft. My next question now would be for Dr. Saba. How would you restore orbital volume loss, and what are the roles of orbital implants in such a situation?
So orbital volume can be restored with a dermis fat graft and with various orbital implants. Now, the orbital implants that we have can be divided into three main categories. You have the integrated implants, which are also known as porous implants, and they comprise of porous polyethylene, hydroxyapatite, and aluminum oxide. Then you have other non-porous or non-integrated implants, which can be composed of PMMA, acrylic, and silicone. The third is quasi-integrated implants, which have an irregular surface to which a prosthesis can be attached. There are various advantages when you compare the two kinds of implants. With the porous implants, they are expensive. They need to be wrapped in some material. It's a two-stage procedure. They can be pegged, which can be coupled to a prosthesis, so they will have excellent motility. As for the other implants, which are the non-porous or the non-integrated, they are inexpensive, easily available, what we commonly use. And my experience with orbital implants has been fairly well. I mean, we haven't had issues with, such as extrusion or migration or infection. And yes, that's about it.
Yes, thank you, Dr. Saba. I agree with you. I think the problem is when you have long-standing contracted sockets, it's difficult to put in these implants. If you have the ability to deal with it earlier on and you can get the muscles, then it's not such a big job for you. So that comes to the next question for Dr. Sofia, Professor Sofia. When would you decide to use a dermal fat graft?
Thank you, Dr. Alyscia. Dermal fat graft is a very excellent procedure for the orbital volume replacement of the socket, as well as to improve the anterior pleural stability, as well as of a thinner prosthesis. It can be done as a primary procedure as well as a secondary. You can do it in children as well as in adults. The secondary is done when there is implant or is an extruded implant. You can primary procedure for congenital anophthalmia after enucleation due to any cause such as intraocular malignancy, severe trauma, or disfigurement. We are doing it as a primary procedure in some of our patients with excellent results. You can also do it where the conjunctiva is deficient because you need conjunctiva only to suture to the edges of the dermis of the dermal fat graft. And the dermis will then provide a scaffold on which the conjunctival epithelium will move, and then it will improve the anterior lining of the socket as well. You can do it in contracted sockets up to grade 3 with excellent results. The only drawback is the prolonged operating time as compared to when you are using an alloplastic implant. It is very, very cost effective, and the common sites are the gluteal region as well as the anterior abdominal wall. If you are using it, the anterior abdominal wall, then it's better to use the left side, because not to confuse it with an appendectomy scar later on in life. Other thing which we have to look after is the fat absorption. In the primary procedure, up to 5 to 10% get absorbed, while as a secondary procedure, up to 30% can get absorbed. So about 20 millimeter chunk would be enough. Initially, it seems very difficult to place because everything you put in will pop out. So start suturing with the edges of the dermis and conjunctiva. Adjacent suture should be applied, and slowly and gradually you replace it, and then you will be able to keep it in place. For the success of this procedure, it's very important we have to select our cases. Remember that in cases where you use a lot of cautery or a lot of irradiation to the socket is given, and where there is severe trauma or chemical injuries, multiple orbital injuries, then the survival becomes difficult. In fact, necrosis may take place, because you need the recipient bed should have a good vasculature for the survival of this graft. So there is no risk of rejection there, and where people cannot afford alloplastic implants, and where I think its use should be advocated. It should be done frequently so as to have the skill. Thank you.
Thank you, Professor Sofia, for an excellent answer. And yes, it is relatively easier to restore the orbital volume with your fat grafts. It's more difficult to maintain the fornices because later on you want to put in a cosmetic shell and you don't get that deep recess over there. So that is something that it's difficult and you may have to do many repeat procedures. The next question is now for Dr. Maya. How would you differentiate a contracted socket from a post-enucleation socket syndrome?
Yeah, thank you. I will need to share my screen, please.
Yes, go ahead.
Okay. So the contracted socket, as we know that it's the socket which cannot retain an adequate size prosthesis. Okay, so it can be either because of the shortening of fornices, that is the surface loss, or it can be because of the contracture of orbital soft tissue, that is the volume loss. So these are the cases where radiation was given post retinoblastoma, enucleation was done, and these are very severely contracted socket with both surface and volume loss. It can be because of any trauma or alkali burn, like in these cases. These have loss of all fornices. This have obliteration of the superior fornix. And then there can be fibrotic bands or scarring post-surgery if the dissection is not done meticulously, as we were discussing earlier. And a lot of conjunctiva and tenons have been dissected and disturbed. Then you can get these fibrotic bands. So it can be classified morphologically also, like anophthalmic socket or ophthalmic socket. So this is a picture of a congenital anophthalmic contracted socket, and these are very difficult to treat because these have associated bony orbital contracture, and these can lead to facial asymmetry also. And serial conformer placement is required for the treatment of such cases. Now coming to the post enucleation socket syndrome, what happens if you are not done any implant, or if you have placed a very small size implant, then there will be a rotatory displacement of the orbital tissues, like the superior tissues will go posteriorly. So you will have a deep superior circus, and there will be the posterior tissues will come inferiorly. So you have this shallowing of the inferior fornix. The fat will also redistribute itself and will come forward. So this will lead to ill retention of the prosthesis. So these are few examples of post-enucleation socket syndrome. You can see a deep superior circus and shelving of the lower fornix. Again, the same patient with the deep superior circus and ill retention of the prosthesis. Thank you.
Thank you, Dr. Maya. Excellent pictures of your patients. And this is a common problem we do see after, reconstruction or after enucleation. Now we're shifting topics. We will be discussing thyroid eye disease. So the first question I have for Professor Sofia: what are the various non-surgical methods that we have to deal with thyroid eye disease? A patient who's having a thyroid eye disease, how would you deal with it?
Thank you very much. Thyroid eye disease is as we all know, is an autoimmune disease, and there's a lot of inflammatory activity focused in the orbit, especially on the extraocular muscle and the orbital tissues, leading to the clinical features of the soft tissue swelling, exposure keratopathy, lid retraction, proptosis, and optic neuropathy. The fibroblasts are the main target here, and they secrete hyaluronic acid when they are stimulated by the circulating immunoglobulins and cytokines, and that hyaluronic acid being hydrophilic lead to all these clinical features. How to deal with it non-surgically depends on the stage of the disease. If it's an active stage or a stable stage, the active stage usually lasts from 6 to 18 months. And here the main focus is to control the inflammation. But again, we have to divide it into mild, moderate, and the severe form of the disease. If it's a mild form, then you can give lubricants, you can tape the eyes at night to prevent exposure, you can give mild steroids or mild decongestants, and you can give diuretics and pillow elevation and all these measures. But usually it's the moderate and the severe form which we deal with commonly. And in that scenario, steroids, radiotherapy, and immune modulator drugs are being used. Steroids can be given orally, as you can give it in the form of IV methylprednisolone, 1 gram daily on alternate days for a total of up to 6 cycles. And if there is improvement expected, it usually happens in the 48 hours. In some cases, you can couple it with the radiotherapy, or radiotherapy can be used alone, usually in a dose of 1500 to 2000 centigrades over 2 weeks' time. Immune modulator drugs are the cyclosporine and the tacrolimus, and they inhibit the production of interleukin-2 by the CD4 plus T lymphocytes, and therefore prevent the clonal expansion of lymphos and check the inflammatory activity. Now, since January 2020, the FDA has approved the new drug by the name of trastuzumab, available as Tepezza, which is very expensive at the moment, and it's a human monoclonal antibody which acts against the insulin growth factor 1 receptors and checks the inflammatory process to the extent with promising results that hopefully decompression surgeries can be avoided in future. Other new drugs are the anti-CD20 rituximab, which helps in the depletion of the T lymphocytes, and drugs like TNT, TNF drugs like nicotinamide can inhibit the synthesis of glycosaminoglycan by the fibroblast. New molecular research has been going on for the identification of the autoantigens and the genes which are responsible for this complex but common disease. Now, coming to the stable stage of the disease, the stable stage is the one in which fibrosis starts and the inflammation has settled down. So it's the rehabilitation stage. And to avoid diplopia, you can give Fresnel prisms, clip-on prisms, etc. And surgery is the mainstay. That is, you have to restore the anatomy of the lid and globe by doing blepharoplasty, squint surgeries, lid surgeries, etc. And you can use gold implants and Botox. Thank you.
Thank you. Thank you. Yes, it's a very exciting time that we are getting all these monoclonal antibodies in every sphere of specialty, not just the retina, but other areas as well. But sometimes we just forget a simple thing, that tell our patient to lubricate the eye with ointment and then state the eye. That will solve a lot of short-term problems. Now the next question is for Dr. Nausheen. At what stage of thyroid eye disease would you consider orbital decompression? Please unmute your mic, Dr. Nausheen.
Sorry. So this question can be answered in two ways. So the shortest answer is, when everything fails, go for the thyroid orbital decompression surgery. Everything includes medical therapy, radiotherapy, intraorbital steroid injections. And so the long answer, or the detailed answer, is when there is sight-threatening compressive optic neuropathy and raised intraorbital thyroid intraorbital pressure, which we also call as hydraulic thyroid eye disease, when there is uncontrollable exposure keratopathy and cosmesis for the disfiguring exophthalmos. So at that time, the thyroid on that stage of thyroid eye disease, orbital decompressions can be done. But it's still more preferable for the moderate proptosis. I would say that in everything, for every surgery, particularly in plastics, we need to communicate with the patient. Very good communication is very helpful particularly in these conditions. It's a safe, we need to communicate that it's a safe procedure, particularly for moderate proptosis, but still has got a complication rate of like numbness in 20 to 30% of the patients. Diplopia can occur from 20 to 40% of the patients. And there is a 1% chance of life-threatening complications in orbital compressions. And just if I have the time, I can, although Professor Sofia has already touched most of the things, just add my 1 cent that among the medical therapy, lubricants have been told, oral steroids, intravenous steroids, and intraorbital steroids, which I'm not sure how much is practiced in Pakistan. It's pretty much practiced in UK over here. And there is a new drug, another coming, which is used in Western Eye Hospital, which was something new for me as well, mycophenolate mofetil, which is certainly could be has reduced the chances of doing orbital decompression in these kind of severe cases. Thank you.
Thank you, Dr. Nausheen. Thank you for your detailed answer. It's a difficult topic, and I think that when you tried everything, all the available resources you have to try to save the vision. And then if you have an orbital surgeon on board, or if you're doing orbital surgery, you can go for it. So the next question is for Dr. Dr. Vanessa. How would you address the skin and the periorbital changes in thyroid eye disease?
Okay, so let me share my screen. I need to go down. So there are many things that we can do for changes of the skin and the periorbital region when it comes to thyroid eye disease. But we have to follow the basic principles. When surgery is being embarked, we first go from in to out. That means first we operate on the orbit, followed by which we go on the extraocular muscles, and the last is the eyelids. So for the orbit, we can do orbital decompression or phac-only decompression. And for the extraocular muscle, the restricted myopathy, we can do screen surgical corrections. And then the last, once everything, the orbit is corrected, the extraocular muscles are corrected, then the last we embark on any abnormalities in the eyelid. So if they have puffy eyelids or excess of redundant skin, we can do a blepharoplasty. Or sometimes if they have lid retraction, then we need to repair the lid retraction either by posterior approach or by anterior approach. And sometimes they can have a secondary entropion. Normally the secondary entropion is because of the proptosis, and generally, once you correct the proptosis by doing orbital decompression, once the eyeball goes inside, the secondary entropion corrects on its own. In some cases, if there's still some residual secondary entropion, then they will need an entropion correction surgery. So this is a patient who had a thyroid eye disease and who had a quite terrible squint. One eye was going upwards and outwards and another eye downwards, and this was him after squint surgery. He didn't have any orbital proptosis, so he didn't need an orbital decompression. So this is another case who had puffy eyelids after because of thyroid eye disease. So when we are embarking on any eyelid surgery, we also, one more principle is we have to wait for the disease to be quiescent and not active. This patient was not a known case of thyroid eye disease. She just came to me for her eye bag correction, but when I saw her, I felt that something was not quite right. She looked a bit hyperthyroid, and sure enough, her thyroid hormones were haywire when I checked her thyroid hormones. So I first started her on treatment, sent her for treatment about 6 months to 1 year down the line when the thyroids were all stable. Then I did a blepharoplasty for her for the lower eyelid. I did a transconjunctival approach. Sometimes when you disturb the skin too much, or if the surgery is a bit traumatic, they can have a flare-up of the inflammation. So for her case, I chose a more simpler approach, a transconjunctival approach, so I don't disturb the skin and the orbicularis. And this is her 1 week after surgery. So in short, when you operate on patients because of thyroid orbitopathy, we go from in to out, first the orbit, then the extraocular muscles, and then the eyelid. It's always best to wait for the disease to be in the quiescent phase, not active anymore, before we embark on any surgical intervention. Thank you.
Thank you, Dr. Vanessa. That was an excellent result of your patient. Now, can you please stop sharing your screen? No. Yes. Okay, so now we're going to the last topic in oculoplastics before we move on to aesthetics, which will be the last topic. We are discussing eyelid lesions, and I'm going to start with Dr. Saba, because this is something that general ophthalmologists or people in other specialties will be seeing in their practice, and we want to discuss a bit about that. So Dr. Saba, what are the common eyelid lesions, and what should you be aware of in classifying them?
Yes, I think you can broadly categorize the eyelid lesions into the common ones that we encounter, the benign tumors and the malignant ones. So the common eyelid lesions that we all seen are stye and chalazion. Then there can be a xanthelasma, which is a lipid-laden histiocytes, comedones, milia. They all can occur in crops. Very commonly what we see may be a sebaceous cyst or cyst of mole, cyst of Z's. Those are the common lesions that we see. The benign tumors include a squamous papilloma, which can be of 3 different types. It may be pedunculated and fleshy, or it may be flat with a raspberry-like surface, or it may be a skin tag. Then there is a basal papilloma, which is a brown, stuck-on appearance. It has a stuck-on appearance. Pyogenic granuloma can be present. Capillary hemangioma, it is the most common benign tumor that we see in children. And pre-malignant lesions such as keratoacanthoma, which has a keratin-filled crater, and another pre-malignant condition such as actinic keratosis, which appears as a scaly plaque in sun-exposed areas. That too is a pre-malignant condition. Coming to the category of malignant lesions, we all know the most common one that we see is a basal cell carcinoma, which morphologically can be in a nodular form or a nodular ulcerative or an infiltrative form. Basal cell carcinoma is locally invasive and non-metastatic. There is a squamous cell carcinoma, which is metastatic. There's sebaceous gland carcinoma, which is associated with the highest rate of mortality, between 10 and 20%. Then we have Merkel cell carcinoma, and there's Kaposi sarcoma. Interestingly, I recently encountered a patient that had multiple lesions on the lower eyelid. And when he was biopsied, it came as sarcomatoid carcinoma, something that I hadn't seen before. So that too can be included in the list of malignant lesions. And because I did not know what a sarcoid carcinoma is, it prompted me to read up on it. And so it is, it's a rare but a rather aggressive tumor. And it has, histologically, it has these spindle cells, which are very characteristic of it. I think that sums it all. Thank you.
Yes, thank you, Dr. Saba, for your detailed answer. I think what we should remember is that when a patient comes to you with a lid lesion, you want to be careful whether it's benign or malignant. So you have to see the patient over some time, get serial photographs, make sure there's no change in the size or in the color, or if it's fixed or if it's mobile. These are the simple things which can differentiate whether it's a malignant or benign lesion. So that comes to the second question for Dr. Maya. When would you perform an incisional or an excisional biopsy, and why would you choose either one of them?
Thank you. I'll need to share my screen, please.
Okay. Yes, please go ahead.
So while talking about when to take the incisional or excisional biopsy, I would say that if you're sure of your clinical diagnosis, like if it is a very well-defined, benign-looking lesion, no loss of lashes, and it can be resected completely, then better to go ahead with the complete excision of the tumor. And if even if it is not benign, if it is malignant, but on your clinical assessment, it is quite resectable. Like in this case, it's quite obvious that it is a basal cell carcinoma with a nodular ulcerative kind of lesion, and you can remove it in toto. It's quite a small lesion. So we can reconstruct it with a bilobed flap, and we can do an excisional biopsy over here with the frozen section control if available, or not, then you can use a wide excision. Similarly, this is again a nodular ulcerative kind of picture that is typical of basal cell carcinoma. And as the lesion is limited to the eyelid, it's not going posteriorly. So you can go ahead with a complete excision of the tumor and do a flap reconstruction. But in cases like these, which have orbital extension, which are fairly advanced, and here you are not able to resect the tumor completely, then you have to take an incisional biopsy and plan a radical excision like exenteration or radiotherapy later on. Then talking about sebaceous gland carcinoma, if it is very well defined, localized, again you do a wide excision or a frozen section controlled excision and do a reconstruction primarily. And this is also a sebaceous gland carcinoma, which is very well defined. Almost it is involving the complete upper lid, but the fornices are free, and we are able to do a complete excision and a cutler beer reconstruction. But if it is a chronic blepharoconjunctivitis type of sebaceous gland carcinoma with the diffuse involvement, thickening of the tarsus, then you are not able to take it out completely. Then you have to do an incisional biopsy in those cases and manage it radically. Again, if the tumor is having an orbital extension, then you have to do an incisional biopsy like squamous cell carcinoma in these two cases. And this is lymphoma, where you do an incisional biopsy and then refer to the oncologist for the further management.
Thank you. Thank you very much for your detailed answer and the pictures of your patients. I would just request that give a little short answers because we might run out of time. I want to keep some time open for the question and answers. So the next question is for Dr. Adeela. When you are managing a patient with xanthelasma, would you use a surgical or a non-surgical procedure?
Yeah, so I think the first thing to understand is, first of all, what is xanthelasma? And we know that it's a collection of lipid deposits within the skin. And then once we've understood what it is, we have to think, okay, well, management isn't just jumping to surgery. We have to think about, okay, well, is there a family history of hyperlipidemia, hypercholesterolemia? And so therefore, you'd ask their general practitioner to investigate and do a lipid profile to determine if there's any underlying cause that could be treated. Then specifically to answering your question about surgical versus non-surgical approaches, my personal preference is always the surgical approach, but when you look out there and see what are the non-surgical procedures that people are actually doing on these xanthelasmata patients, you will find that there are people doing liquid nitrogen cryotherapy for xanthelasma. There are people doing YAG Q-switched and non-Q-switched laser treatments. There are CO2 lasers. I mean, in the cosmetic world, you name it, there's probably a laser instrument that people will try to treat this problem. But in my very humble opinion, I don't think they work long term, in that I've seen patients where they'll be lasered and then they'll come to me and say, look, first of all, this didn't completely go, and then it came back, after sort of 6 months to a year. So that's why I tend to use the surgical approach, which is to fully excise the area, cautery to the base. And when I consent the patients, I will always tell them that the success rate of a xanthelasma excision is between 80 and 90% at 10 years. And I will always say to them, if it does recur and you have treated and you've remembered to treat any underlying hypercholesterolemia or hyperlipidemia problems, come back and I will, of course, do a re-excision. But I feel it gives the longest eradication of a xanthelasma compared with non-surgical approaches. So for me, I would always use a surgical excision approach.
Yes, thank you, Dr. Adeela. You're really right. I also find the surgical approach is the best, but this is an ongoing fight, I think, between dermatologists and ophthalmologists. So let's see who wins in the end. So the next question is for Professor Sofia. Chalasia are commonly seen in the pediatric age group. So do you treat them similarly as you do for adults, or do you have a different approach?
Thank you, Professor Alyscia. Chalasia is commonly seen in all age groups, not only pediatric age groups are we saying, and pediatric age group is a very wide range, starting from 0 to 16 years. And they are usually painless nodules on the upper or lower eyelids, and due to the obstruction of the meibomian glands, and its secretions, when they permeate into the surrounding tissues, can excite rheumatous reaction. The commonest thing is its recurrence, because since there are about 40 chalazion in the upper eyelid, 40 glands in the upper eyelid and 20 to 30 in the lower eyelid, there is tendency to for the recurrence. The commonest causes are, as we all know, is chronic blepharitis, acne, rosacea, seborrheic dermatitis, and certain viral infection. And in adolescent age, where there's a lot of hormonal changes going on, sebum production is more, so we see it quite commonly. Now, the treatment mostly is medical because most of them resolve on their own, but some of them can get bigger and they can discharge through the tarsal plate and very rarely through the skin as well. When they get infected, then we have to treat with oral antibiotics as well. Otherwise, treat the underlying cause like chronic blepharitis. In case of toddlers, you have to instruct the mothers to carry on the lid hygiene as well as the hand hygiene, and control the seborrheic dermatitis and acne rosacea and all that. Common treatment is usually warm compresses. You can do it 2-3 times a day, and gentle firm massage so that they can be expressed easily. Otherwise, mild lubricants and mild steroids can be given. If they get bigger, then you can give a triamcinolone acetonide injection, but personally, I have never used it, and it can cause depigmentation as well as the eyelashes loss. In case of bigger chalasia, then you have to do surgical incision and curettage. And in case of children, then you have to give short anesthesia because they're not cooperative enough to undergo the procedure. So as we all know, chalazion clamps are available in different sizes, and you invert the lid and you use a number 11 or number 15 blade, avoiding damage to the lid margin, and you don't suture it, and then you just close it once after you scoop out the secretions. For the prevention, lid hygiene is very important in treatment of the underlying conditions. Lid scrubs are available, and they should be advised to use them and should be instructed how to use them. One important thing I want to highlight for the adult age group is if you're seeing recurrent chalazion, and if you are suspicious, it's better to biopsy that, because sometimes, very rarely, a sebaceous gland carcinoma or a squamous cell carcinoma may mimic like a chalazion. And in that scenario, it has to be biopsied and sent for histopathology. Thank you.
Thank you, Dr. Sofia. Yes, I agree. We try to avoid general anesthesia in the pediatric age group, and they do resolve in the majority of cases with medical treatment. I think, Dr. Nausheen, you have your hand raised, but can I just move on? Okay.
No, I think this happened accidentally. I was trying to fix it.
Okay. I'm just going to move on to the next question for Dr. Saba. What is your experience in using intralesional agents like bleomycin in vascular lesions in the periorbital area?
Yes, can I please share my screen?
Yes, please go ahead.
Some other participant is sharing her screen, so
All of
I'm
you,
unable to share mine.
can all of you stop sharing your screens? Then she will be able to share hers. Can you do it now, Dr. Saba? No?
I'll try. Is it visible?
Yes, please go ahead.
Right. So bleomycin can be used for lymphangiomas and for orbital varices. And this is a case, this was a child about 2 months of age, and clinically he had this translucent swelling in his lower lid, as you can see, and had a bluish tinge to it. We thought it was a lymphangioma, and then what we did was that we did an ultrasound on him, and we located the cyst, and we took bleomycin. Now, bleomycin comes in a freeze-dried form, and you can dilute it with crystal water. And what you do is that the dose is about 0.25 to 0.5 mg per kg. And you will dilute it with water, and the amount of water that is used for dilution actually depends upon the volume of the lesion. So say you have a lesion which is 2 by 3 by 1. So that would amount to 6 ml. And you dilute the bleomycin in that, and you can inject it into the lesion. Now, before you inject it, if the lesion is visible clinically, you can just inject it directly. If it isn't, you can use ultrasonic guidance. And then you can first aspirate, whatever fluid that is, and send it for cytological analysis. And then whatever amount that you've aspirated, you should inject 20% of it. So this is it visible? It's actually a B scan that shows you a retroorbital cystic lesion. And then this is how we're trying to locate the lesion. This is the amount of fluid that was aspirated. And so my experience with lymphangiomas in particular has been that it is, they do reduce considerably. I haven't had 100% resolution, but I would say about 80 to 90%. And in this particular trial, we had to repeat it 3 times. We did it, every once in 4 weeks. And I think after our 3rd attempt, it was considerably reduced. So yes, thank you. I actually also have a small video just to show.
I think, Saba, we will be short of time. Yes, I'm sorry, we'll be short of time.
No, that's all. Okay.
But, really interesting and excellent case report on your patient. Now I will move to the next question, and this is our last question in the Ocuplastic section. This is for Dr. Vanessa.
Hi. Yeah, can I share my screen too?
Let me just ask the question, then you can go ahead. So what concerns would you have in dealing with lesions in the medial canthal area?
Okay, so the medial canthal area is actually quite tricky for oculoplastic surgeons because there are many important structures there. And the structures that are present in the medial canthals are the tear duct and the medial canthal tendon. So I'll just go through a few slides and so we can have a kind of brief idea. So this is a patient with a melanoma of the medial canthal tendon, medial canthal area. So when there's a melanoma in this area or any tumor in this area, we have to be a little bit more aggressive in the management because this area is rather vascular and any tumor, especially melanoma, they tend to spread rapidly and they have a poor prognosis. So we have to be more aggressive in the management of these kind of cases. So he went extended excision with cryotherapy and mitomycin C eye drops, and he did quite well. This is 5 years on and he's still alive and doing well. And another problem with the medial canthal tendon, medial canthal area is the tear ducts. So when you have a laceration of the medial canthal region, you can have avulsion because it's injury to the medial canthal tendon, and also the tear ducts which are there need to be reconstructed. So in this boy, like we had a cradle hook injury, we reconstructed the medial canthal tendon and also the tear passage, and this is him after surgery. If the medial canthal area is not properly reconstructed, then they can have this telecanthus, wherein the medial canthus is displaced laterally, and also the medial canthal area is very prone to scarring. So we have to keep this in mind, and any procedure we do in the medial canthal tendon, always inform the patient that this area is prone to scarring and it will take quite long to heal. Also, the skin in the medial canthal area is quite tight. So when you reconstruct, it's very difficult to mobilize the skin. So you generally need to do flats. So you also need to warn patients that if you, after excision, the patient will need flats, and also that they will have some amount of scar and they should be willing to accept. And sometimes you have to follow them up frequently and see if they have a scar, then you need to give them steroid injections or some kind of treatment or 5-FU injections to improve the scar. So in short, medial canthal area has important structures such as the medial canthal tendon and the tear duct, which need to be considered when you're dealing with the medial canthal area. And also that the skin in the medial canthus is tight, is prone to scarring, and also the medial canthal area is very vascular and malignancies can spread and metastasize fast, and one has to be quite aggressive. And medial canthal area is supplied by the 7th cranial nerve, and if there's an injury to the 7th cranial nerve, they can have an ectropion and tearing, and they need to be repaired. So these are all the concerns with the lesions in the medial canthal area. Thank you.
Thank you very much. That was
Very short.
Now we are going to move on to our last section of this webinar, and this is dealing with aesthetics. So with the first question will be for Dr. Adeela. So we see these different disorders or different age-related changes, you could say, like hollow eyes and under eye bags. So what is the mechanism of these appearances, Dr. Adeela?
Yeah, so when dealing with any cosmetic eye condition or periocular condition, I always think the most important thing is to understand the underlying condition, because only if you understand it can you then treat it to the best of your ability. So people often group these two things together as the same thing, but they're actually two totally different situations. So hollow eyes can be caused by, I mean, the most common thing the cosmetic world will tell you is dehydration. It can be due to aging, where you will get cell atrophy of the muscles, and you can also get some thinning of the skin. Lack of sleep. It's very common for there to be a genetic predisposition. So you'll sometimes meet patients who have sort of families of dark circles around their eyes that look very hollow. And also weight loss or weight gain. And enophthalmos is another cause that people sometimes forget. So it's not always just, oh, I woke up and I didn't look right. It's what was the underlying condition that predisposed you to have this problem, and therefore can I choose the right cosmetic method to treat the problem. So that's hollow eyes. And then we move on to baggy eyes. This is something that when patients see me in the clinic, I always ask them, do you have any underlying renal problems or heart problems, things that could lead to fluid retention in the periocular area, which can lead to eye bags. Again, lack of sleep can also be a reason for eye bags. It can also be genetic. But one of the most common things that I see when I operate on patients for lower lid blepharoplasty is that I find there is a thinning of the orbital septum around the medial, middle and lateral orbital fat pads. And so as a result of the thinning of the orbital septal wall, there is a prolapse of these fat pads, and then they can get the baggy eyelid appearance. If you look in the literature, they also relate baggy eyes to smoking, aging, but the main things are the things that you can treat, which are, do they have any underlying renal or heart problems that could be causing fluid retention, which could then be treated before you then think about doing any cosmetic surgery for hollow eyes, sorry, for baggy eyes.
Thank you, Dr. Adeela. That was a wonderful answer. Now moving on to the next question. This is for Dr. Maya. What are the approaches to lower eyelid blepharoplasty, and how does it differ from upper eyelid blepharoplasty?
Yeah, I'll need to share my screen again.
Yes, please go ahead.
So as we know, in the upper eyelid blepharoplasty, the approach is always transcutaneous, and you remove the excess skin, which is measured by the skin pinch technique, and raise a skin or skin muscle flap, excise the fat conservatively, and then form a lid crease and close the wound. However, in the lower lid, it depends on whether the fat bag is associated with any excess or loose skin or any lid laxity to decide the approach. So for example, if the patient is having only fat bag without any excess skin, then we can go ahead with a transconjunctival approach to excise the fat over here. And if the patient is having excess skin or lid laxity, we can address the condition by a transcutaneous blepharoplasty. And this is the skin flap technique. Also, we can address the laxity by transcutaneous approach and the same sitting by doing a lateral tarsal strip procedure. However, we nowadays are preferring to do a fat repositioning or redraping the fat to fill this inferior orbital hollow instead of excising the fat, particularly in the young patients. And this is done in the lower eyelid when you reposition the fat over the periosteum and suture it with the periosteum, and this will cover the inferior hollow of the orbit rather than excising it. I'll just skip the video for the interest of time.
Thank you very much, Dr. Maya. That was really nice. Now I'll move to the next question. And this is for Dr. Saba. So what is a tear trough deformity and what methods are used to treat it?
Yes. Can I please share my screen? Because I think in order to understand it, we need a visual.
Yes,
See
please
this
go ahead.
picture. Right. if this is visible to everybody. So a tear trough deformity is essentially this concave deformity that you see on the lower lid, right? So it's near the inferior orbital rim. And there are three factors for why it occurs. That is because of loss of elasticity of the skin. Then there is maxillary hyperplasia, and there is loose orbicularis retaining ligament. Now, the tear trough deformity can be divided into class 1, class 2, and class 3. So in class 1, you see that there is a concave deformity at the nasal part of the lid, and there is no associated fat bulge or excess skin. In class 2, what we have is that, you have the deformity that has extended medially, and it is associated with a bit of a fat bulge, which wasn't evident in class 1. In class 3, now we notice that the concave deformity has extended medially all the way laterally. There's excess skin and there's a fat bulge. So the treatment of a tear trough deformity is basically on the stages. If you have a class 1 or a class 2 and you see this concave appearance, you can inject hyaluronic acid fillers, or you can use autologous fat, and that you can take from the thigh. As for the class 3, now in class 3, because you have excess skin, you have a fat bulge, and you have a nasal deformity. So for that, what we need to do is that we're actually going to do fat repositioning and a bit of blepharoplasty. So you take fat from where it's protruded, that's basically the lateral end. You cut it into tiny segments, and then you bury it deep in this trough to sort of make it elevated. And that's the treatment of it.
Thank you. Thank you, Dr. Saba. So the next question is for Dr. Vanessa. So we hear these brand names, Restylane, Juvederm, a lot, and we're hearing it more and more now in our plastic practice. So what are these names? What do they signify? And when you use it, is it a single treatment? And how long does the result last?
Thank you, Dr. Alyscia. So with the advances in time, in the yesteryears, the periocular rejuvenation was done by means of blepharoplasty, wherein we used to remove the skin and remove the fat to rejuvenate the eyelid and the periocular area. As time goes by, there is changes in the understanding, and it is a known fact that as we age, there's a loss of volume and there's a resorption of bone. So then comes into play Restylane and Juvederm. So these two agents are basically fillers. They add volume to the periocular area by means of, they contain hyaluronic acid, which hydrates and adds volume to the periocular area. It also promotes fibroblast activity and also improves collagen synthesis. So it adds volume, it reduces fine line, and it reduces wrinkles. Is it a single treatment? No, these Restylane and Juvederm fillers normally need to be injected. Generally, one injection lasts for, they are basically deep fillers. If you inject in a deep plane, which is quite common for periocular rejuvenation. So generally, one treatment will last for about 18 months. And after which you might need to top up the treatment. One has to be very careful with fillers, unlike Botox, which is more forgiving because the effect wanes within about 4 to 6 months, and the side effects are quite rarely permanent. With fillers, one has to be careful. When injecting fillers, one has to be injected in a very extremely sterile environment so as to prevent infection and inflammation. One also has to be careful with fillers because sometimes they can enter into the vascular stream and give rise to blindness. So during injection, the proper technique, as in very slow injection and small aliquots, and looking into the face for any face of the patient, we're looking for any expression such as pain, and if you see there's a slight pain and expression of the patient, then one has to wait for a while, withdraw and come out, make sure you're not in some vasculature. And all this technique, proper technique of injection is very important with fillers to prevent any serious complication. And once a person who injects fillers also needs to know that if there's a complication, how to manage it. So you need to keep standby your hyaluronidase, which has to be on standby just in case there's any vascular entry into the product. You can kind of dissolve it by injecting the hyaluronidase. So basically Restylane and Juvederm are fillers. They add volume to the periocular region. They are used for rejuvenation. patients should be seen properly and see it is mainly for hollowness. But if the patient has excessive eye bags and loose skin, then obviously it's not a right candidate for the filler injection, and proper technique and watching for complications is very important when using fillers. Thank you.
Thank you, Dr. Vanessa. So I think the important take-home message is that people who are using these fillers or Botox, they should know what they're doing. A lot of times, a lot of unqualified people are using it now. You should be ready to deal with any complication and manage it as such. Now we will go to the next question, and this is for Dr. Nausheen. For deep creases around the eyelids, would you use Botox, fillers, or a fat transfer? What are the advantages and disadvantages of each procedure?
So for first of all, we need to know that what is the cause of the deep creases? Is it due to a soft tissue atrophy? It is due to some trauma? Is it due to injury? Is it due to the sun damage, or due to the aging or wrinkling effect? Genetics can also play a great role in these kind of fine wrinkles and deep creases. So first of all, the Botox, which just blocks the contracture of the muscle, my vote is not into that, because this Botox gives short-term results. It's not good for because it can cause or exaggerate bagging or sagging of the lids, and it may cause difficult blinking. And what I have observed from my experience, that Botox, like we do say that it's gonna give results for 3 or 4 months time, but the maximum effect comes up when there is a waning period, when the Botox effect is getting decreased. I think that is the time when the maximum desirable effect is achieved by the patient. So patient satisfaction cannot be done with this Botox. Then comes the dermal fillers, which have got 4 varieties. They could be hyaluronic, collagen, synthetic, and autologous. Autologous has got fat and PRP, which is very common, plasma, platelet-rich plasma. So among the fillers, hyaluronic acid, Restylane, Juvederm, Dr. Vanessa has already elaborated very well about it. These hyaluronic fillers are more good, give more good results in eye area, because eyes are less mobile as compared to lips and cheeks. So, and complications can occur: scarring, visual impairment. These are the, can be long-term and rare complications, but the immediate and early could be redness, tenderness, allergic reactions, lumps or bumps, overcorrection, undercorrection. Then comes the synthetic dermal fillers, which are more preferred for deep tissue, deep creases. For example, Brady's, which is a calcium hydroxyapatite, which is preferred in moderate to severe creases, gives a very natural results. And there again, the results can be long lasting. In complications, as I've already told before. But the most important thing is, like the silicone in the synthetic fillers can give other way around. It can give disfiguring effect if it's not used properly, and as you mentioned, that if it's not used by an expert person. Then comes the collagen fillers. The collagen fillers initially were extracted from the cow, which gave very bad allergic reactions. Now they are produced in the laboratory, synthetically grown. They give very natural results again, but they are not long lasting, because body tends to disintegrate collagen. So you have to give refills or around 2 to 4 sessions per year, depending on the patient's demand and the severity of the disease. Again, the risks are bruising and allergic conditions, lumps and bumps. And then comes the fat. So I believe because I have done most of the fat procedures, so this is my understanding, chubby people have always got very less aging effect. So, but dealing with the fat, you are going to have, you need, again, communication with the patient, that the patient is going to have 2 procedures. First, removal of the fat, and then injection of the fat.
Thank you. Thank you, Dr. Nausheen. I'm sorry, you're over the time limit and we're towards the end. So I would like to ask the next question from Dr. Sofia. So are there any complications using Botox too frequently since it has become a routine office procedure? And please stay within your 3-minute time limit, please.
I will. Thank you, Professor Alyscia. Botox is one of the most commonly used drug all over the world, and it is commonly used in ophthalmology for lots of conditions like essential blepharospasm, hemifacial spasm, spastic lower lid entropion, and as we said earlier, to induce ptosis in non-healing corneal ulcers, as well as to counteract lid exposure in lid retraction. It is also used in cranial nerve palsies, intermittent exotropia, and certain strabismus associated with thyroid eye disease. It acts by inhibiting the release of the acetylcholine at the motor end plate and temporarily paralyzing the muscle for a period of 3 to 6 months. It is cosmetically used for conditions such as frown lines, crow's feet, glabellar lines, Burry's lines, chin lines, neck lines, and nasolabial folds, etc. It is considered to be generally a safe drug, but there is no such drug that has no side effects. So some of the side effects are related at the site of injection, which happens when you give an injection like erythema, itching, pain, urticaria, bruising, and sometimes you may hit on the nerve, and sometimes if the needle tips are infected, you can get infection. The serious most side effect is, we all know, is botulinism. It's very, very rare, especially for cosmetic use, but one should be aware of its existence. The other thing is, remember that when you inject Botox, it permeates up to 35 to 40 millimeters from the site of injection, even if the muscles are separated by fascia. So if you give at improper site and the dosage is not being monitored, then you can end up in peribulbar area with condition like xerophthalmia, watering, ectropion, ptosis, brotosis, and you can end up with exposure and nasolabial fold area. You can get drooling of the saliva. And in the neck area, you can get dysphagia, dysphonia, dysarthria. How to deal with that is not this is not the forum for that. But the other question was frequent use. Remember that it's not an anti-wrinkle drug, although the impression is that it's an anti-wrinkle drug, but it just acts by paralyzing the muscle. The aging process of the skin will be according to the age of the patient. It doesn't stop that. So over a prolonged period of time, the muscles can go in disuse atrophy. The muscle mass can reduce, and some studies are coming up with a reduction in the bone mass as well. So with that atrophying effect is more in obese patient and patient with type 2 diabetes. So with all that combined, bone mass reduction and muscle mass reduction, the volume of the face can be affected, and it's less. So the overlying skin can become sagging, it can become more friable and shiny, and you can give an expressionless look to the face. The most important point here to note is that before embarking upon this long journey of Botox use, it all has to be explained to the patient in detail of its long use. And the other thing is that it has to be used in FDA-approved doses, and people who are certified in using that, because these days everybody is trying to use it because of the ease, availability, and predictable results, but it has got its long-term effects. Thank you.
Thank you, Professor Sofia. Excellent answer. And that's really true. Everybody is using Botox. It seems to be just like, using a pen or something. So we have to be careful with dealing with the complications. And I have seen many cases of ptosis coming in due to Botox injections. So you have to reassure your patient. So that comes to the end of our webinar. And I think we had an excellent time keeping. All of you were within your time. I did interrupt one or two speakers, and again, I apologize for that. So we have 1 or 2 questions from the audience, and I am going to put the first question to Dr. Maya. So this question was from Sayyid Noor, and the question is, which procedure will you prefer for a non-healing corneal ulcer, amniotic membrane graft, conjunctival flap, or a pillar tarsal FE? So Dr. Maya, please go ahead.
Okay, so first of all, I'd like to see what is the etiology of that non-healing corneal ulcer, although it's an oculoplastic webinar. So if it is there any systemic causes there, like uncontrolled diabetes or any chronic immunocompromised situation, I'd like to first control over that. Then I'd like to first scrap the corneal ulcer, and this itself promotes healing by epithelialization. And then I'll prefer doing any amniotic membrane transplantation. I have no experience with pillar tarsorrhaphy. As Dr. Nausheen has already written, it is not advisable to do a pillar tarsorrhaphy if there is a impending perforation or desmetocele, and she has advised to go ahead with the conventional suture tarsorrhaphy. So if the non-healing ulcer is caused by facial palsy related leg ophthalmos causing exposure keratopathy, then first and foremost thing is to do a tarsorrhaphy, because eyelids are the defense mechanism of the cornea, and the ulcer will not heal unless it is covered. So that is my answer.
Thank you very much, Dr. Maya. That excellent answer. There was one comment from Kumbal. What about dermoid cyst on the upper eyelids? So I don't know if this, what is the question about dermoid cyst? Anybody wants to answer? It's open for the speakers. I don't know what the question is, but dermoid cyst are common lesions we do see on the upper eyelids. If you want to make any comment on this.
Exactly.
I could say one thing that I think is really important. You should always scan your patient who has a dermoid cyst so that you can track how far back or posteriorly the extension of the dermoid cyst is. Because if you jump straight into surgery, you may find that you could end up with CSF leak or all sorts of problems because you haven't checked to see its posterior extension. So that's the one most important key thing I would say is always do, you know, a scan to check how far back and how big the lesion is. And it also helps you to plan surgically for when you do decide that it is safe to then do an excision of the dermoid cyst.
Also, when you're excising a dermoid cyst, I feel you need to have a lot of patience because it takes time. And just when you're nearing the end of your surgery, you're so tempted to like snip it all off. And that's probably the time when you're bound to rupture it. So you have to do it really gently and really patiently.
Yes, that's true, Dr. Saba. Anything else? Does anybody else want to make a comment about any of the previous questions? I think we have 1 or 2 minutes more before we end the session.
Can I add one sentence for the xanthelasma treatment?
Please go ahead.
Dr. Adeela, she gave a very elaborative answer. This is one thing which I saw in Western Isle, again was new for me. Use of trichloroacetic acid. It cannot completely resolve the xanthelasmas, but it certainly can reduce the intensity, and later on you can excise it. Eventually, I totally agree with her. So the eventual approach should be always the surgical about xanthelasma. But this is, I have seen something new which can reduce but it can only be used in cases of severe xanthelasma lesions.
Thank you very much. I think now I've been told that we are towards the end of the session. The time has run out, and I would once again like to thank all of you ladies from all around the world for participating in the Women in Ophthalmology Pakistan's webinar. It was very nice to meet all of you and hope to have you again. And thank you very much.
Thank you for having us.
Thank you very much.
Thank you, Professor Alyscia.
Thank you.
Thank you, WIOP, for having us here.